Go.
Good morning, I'm Josh. I'm a third-year medical student working with the team today, and this is the rest of the team. So we're going to be talking a little bit about what brought Matt and you into the hospital, and please feel free to correct any mistakes that I make in the history or ask any questions that you have. How are you guys doing this morning?
We're doing good.
Sounds like he's doing a little bit better. Okay. So Matt is a 2-year-old male who has had a 3-day history of cough and is now presenting acutely with increased work of breathing and intercostal retractions. Mom endorses rhinorrhea and that the cough has been worse at night, associated with one episode of non-bilious, non-bloody post-tussive emesis this morning. He had a temperature of 100.8 2 days ago, but has not had any temperature taken since due to the thermometer, I guess, had broken. Mom reports several other children from his daycare have been home sick, possibly with similar symptoms. The cough has not been relieved by over-the-counter medications such as Dimetapp, Vicks Vapor Rub, humidified air, or saline nose drops, but she does note improvement following the use of his younger brother's albuterol. Past medical history: Matt is a full-term male who was delivered spontaneously without complications. Immunizations are believed to be up to date. He's had a history of 3 ear infections over the past year, with and of note in his history he had an episode of wheezing at about 12 months of age. He's also had eczema since early infancy. Medications: his only medication right now is hydrocortisone cream for his eczema. He has allergies. He's allergic to eggs, but no known drug allergies. Family history is pertinent for a 3-month-old premature brother who takes albuterol for breathing problems, and dad has a history of asthma as a child. For social history, he lives with mom, dad, and a 10-year-old sister and 3-year-old brother, and attends daycare. Both parents smoke, but outdoors. Review of systems: so general, he had a fever with decreased activity. ENT was positive for congestion, but negative for ear or throat pain. Respiratory was positive for cough and shortness of breath. GI was positive for 1 episode of emesis, but no abdominal pain or diarrhea. MSK was negative for joint pain, and skin was positive for eczema. Physical exam: so his vitals showed a temperature of 37 degrees Celsius, so he was afebrile. He was tachycardic at 120 beats per minute, and tachypnic with a respiratory rate of 45 respirations per minute. Blood pressure was 100/65 with a pulse ox of 94% on room air. General, he was alert in moderate distress. HENT, his tympanic membranes were on the left side was partially occluded with cerumen. The right was pink with good cone of light reflex. His nasal turbinates were noted to be edematous with clear nasal discharge, and the pharynx was erythematous but without exudate. Neck was positive for multiple 0.5 by 1 centimeter soft mobile lymph nodes palpated over the posterior aspect of the neck, and there was no JVD noted. Lungs exam: he was tachypnic with inspiratory and expiratory wheezes bilaterally, decreased breath sounds in the bases with subcostal and intercostal retractions. Cardiac exam was regular rate and rhythm, normal S1 and S2 with no other added sounds. Abdomen showed a scaphoid contour, was positive for bowel sounds, soft, non-tender, non-distended, with no masses palpated, and no organomegaly noted. Neuro was within normal limits, cranial nerves 2 through 12 intact, with no focal sensory or motor deficits. Skin showed dry, scaly, mildly erythematous 2 by 2 centimeter patches of the abdomen and back. Labs showed a white blood cell count of 13, most notably 50% lymphs, so increased lymphocytes, hemoglobin of 13, hematocrit 35. Chest x-ray showed a flattened diaphragm, hyperinflation with peribronchial thickening. So as far as assessment and plan, Matt is a 2-year-old who presents with a 3-day history of cough, which is worse at night, 1 episode of non-bilious, non-bloody post-tussive emesis, now with increased work of breathing, intercostal and subcostal retractions. He's now tachypnic with increased work of breathing. Given his present chest x-ray findings of hyperinflation and his responsiveness to his brother's albuterol inhaler. This patient's presentation is most consistent with acute asthma exacerbation. Also, viral upper respiratory tract infection must be considered in the differential given his exposure to ill classmates and his elevated lymphocytes on exam, in addition to the positive cervical lymph nodes and the pharyngeal erythema and rhinorrhea. But this may have contributed to his current an asthma exacerbation. So as far as plan goes for respiratory, albuterol 2.5 milligrams Q2 hours via nebulizer, methylprednisolone 1 milligram per kg BID by IV, 100% O2 via face mask. To SATs greater than 94% and cardiorespiratory monitor at this time. For derm continues 1% hydrocortisone cream for eczema. As far as disposition goes, pending stabilization of his respiratory status, decreased work of breathing, and tolerating albuterol nebs Q4 hours with O2 sets maintained above 94% for 24 hours, and an asthma action plan in place, he will be ready to go home. Any questions?